Starting us off this afternoon is Dr. Laura Toshin, a pediatric neurologist at Children's National who specializes in movement disorders. Dr. Toshin works closely with LCC and their families to better understand changes in movement and function. Today, she's going to discuss seizures and epilepsy in LCC. Please join me in welcoming Dr. Toshin.
I'm really excited to be here with all of these familiar faces and new faces. So today we're going to be talking a little bit about seizures and epilepsy, specifically in LCC, but also in general. So no disclosures relevant to this. My consulting and honorary have nothing to do with LCC in particular. Some of the goals of what we're going to try and accomplish in the next 20-ish minutes are to define what is a seizure, what is epilepsy, go over some of the terminology, hopefully try and break it down so it's a little bit more digestible and understandable, go over a framework for how neurologists think about categorizing epilepsy or seizures, and then use that framework for how we would specifically manage seizures in LCC. So first of all, what is a seizure? I said we were going to demystify terminology, but I've put a lot of jargon up here first. So this is a neurology definition of seizures. So the International League Against Epilepsy defined seizures in 2005 as a transient occurrence or signs, symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. That's a lot of words. And when you put them all together, it is kind of hard to understand what that means. So this is maybe more of a patient-friendly definition of a seizure. So a seizure is an abnormal burst of electrical activity in the brain that causes a change in one or more of the following things: your level of awareness of your surroundings, your behavior, your movements, or your feelings. So hopefully that makes a little more sense. So when we're thinking about a seizure, I like to think about seizure like everyone has a seizure threshold. So any brain essentially has the potential to have a seizure, and certain things might make that more likely to come out, like infections or trauma or sleep deprivation. So even someone who doesn't have epilepsy has some potential to have a seizure, and so the seizure potential is this like iceberg, it's under the surface. And in someone who doesn't have epilepsy, it's going to take a whole lot, and it's going to be pretty unlikely that iceberg is going to pop up above the surface of the water. All right. So just even with normal motion of the water, your iceberg stays under. You don't see it. But in someone who has epilepsy, just normal waves, movement of the water, every once in a while, the tip of the iceberg is going to pop up above the surface of the water and you would have a seizure. Okay. So there's just that in a brain with epilepsy, that iceberg, it sits higher in the water. So it's more likely to pop up above the surface. Okay. So that's the threshold that we can reach. As neurologists, we like to think about different types of seizures. So this is also from the International League Against Epilepsy. At this point in time, we categorize seizures based on how that seizure starts. Is it what we call a focal seizure, meaning it's starting in one particular part of the brain? Is it a generalized seizure, meaning it starts all over throughout the brain? So in a focal seizure, you might have one part of your brain that has maybe a structural difference to it. So like an LCC with a cyst or something like that. And that is where your seizure starts. From that one focus in the brain, that can spread from there. So it could involve more of that particular side of the brain, like this. Or it could even spread to involve the other side. All right. And so a focal seizure, even though it starts in one place, can spread to involve both sides. By the time that happens, we generally expect that people are going to have an impairment in their consciousness if it's involving both sides of the brain. But what we really truly care about in neurology is how is it starting? All right. If you walk into the room and someone is having a seizure and you see a full body involvement of their seizure with unconsciousness, you actually don't know if it started as focal or it started differently. So they can look very similar later on, but how it starts is really important to us. And we'll talk a little bit about why that's important, as opposed to generalized, which is when it starts throughout the brain all at once, like this. Okay. And then we have this additional category of unknown for the reasons I just said. If you can't actually tell how it started, you might not actually be able to categorize it further. But this is really important for us. And this has a lot to do with why we're going to ask you certain questions about your seizures and how it starts and what it looks like, because we want to know, is it focal? And that's going to have big implications for our treatment and how we're going to do things. Here are some of the evaluations that you guys might be familiar with, or that in someone who has seizures, we might want to be looking at. So an EEG is looking at your brain waves, okay? There are a couple different things that we're trying to understand from an EEG. We're looking for something called discharges. So even though I just used an iceberg analogy, I'm going to switch it up a little bit. So if you think about more like a seizure as something that kind of catches fire, discharges are more like the sparks. You might get sparks that fly, but it doesn't catch into an actual full-blown fire. And so that's what we're looking for in one aspect of an EEG. So we're looking for discharges. Are there sparks in a particular area of the brain that can help us identify is that the focus for where seizures could happen? And then in a longer EEG, we might be looking for actual seizures so we can characterize them even further. And so here are some examples of what we were looking for in an EEG. So here's an example of discharges. So EEGs, a lot of squiggly lines. Discharges really show up as sharp things. At one point, someone told me they're the ones you don't want to sit on. And so here we can see focal discharges as opposed to in this next EEG. So here we can see, where's the pointer? All right, so these are discharges, but it does not catch fire into an actual seizure. Here we can see discharges that are starting just in one particular part, but that it evolves and builds up and then starts to involve all of these brain waves, and that's a focal seizure evolving. Okay. And then in addition to that, we're oftentimes going to do imaging. So we might do an MRI, and in LCC, we might be doing CTs as well. And so an MRI is going to give us useful information about the structure of the brain, myelination, cysts, or other areas of structural difference. And a CT is going to help us see calcification more. So here's both an MRI and a CT. You guys have seen multiple pictures of MRIs and CTs so far. So we've talked about what is a seizure, different types of seizures, but what is epilepsy? Is every seizure that happens is that the same thing as epilepsy? And honestly, the answer is no. But here's what the difference is. So this is actually from updated criteria or a definition that was put out again by the International League Against Epilepsy in 2025, so fairly recent. And here's how they defined epilepsy. So epilepsy is a disease, and actually that's new terminology for them to call it a disease. We still have to think about the fact that multiple etiologies could lead to epilepsy, but it does put a little bit more power behind that as a diagnosis rather than calling it a syndrome or a disorder. So epilepsy is a disease in which someone has had at least 2 unprovoked seizures more than 24 hours apart. That's really still part of the old definition too. That's how we were defining epilepsy for many years. And unprovoked really means that it's not associated with an infection of your brain specifically, a trauma or something like that. Or that even if you've not had more than one unprovoked seizure, if you have had one unprovoked seizure and that we deem that your risk of having an additional seizure within the next 10 years is more than 60%, that is also enough to provide a diagnosis of epilepsy. That's actually really helpful because in people we do think are high risk, we might then move towards putting someone on an anti-seizure medication, for example, sooner than we would have otherwise. But you can also think about how in certain rare diseases, that's a little bit challenging. How do we decide that someone's risk of additional seizures is 60% or higher in something like LCC? So it comes with some challenges as well. And then it includes a diagnosis of an epilepsy syndrome that's a little bit less relevant to LCC specifically. That's more for things like absence epilepsy or things like that have a more defined syndrome with them. Another thing that I actually think is helpful in this new definition is that previously we didn't have a mechanism or an off-ramp really for people to outgrow their diagnosis of epilepsy or resolve their diagnosis of epilepsy. And at this point we actually do. And so if they have had a specific syndrome where we know they're likely to grow out of it, or if they have remained seizure-free for an extended period of time and not been on seizure medications for an extended period of time, then their epilepsy can be considered resolved. So that's actually helpful. So again, the reason we want to be able to define these different types of seizures is because it does have implications for our treatment and our management. Some of these medications might look familiar to some people. So if we know that someone has focal onset seizures or focal onset epilepsy based on the evaluations that we've done, we have a certain number of medications that are of a narrow spectrum and are helpful specifically for focal seizures. And we also have broad spectrum medications that can treat both focal seizures and generalized seizures. So if someone either has tried the narrow spectrum medications and it's not been helpful, we can use broad spectrum. If we're unsure about their seizure type, or if they have generalized seizures, we can use these broad spectrum medications. And we'll talk a little bit more about some medications in a little bit too. So the goal of these medications is to, again, work on the seizure threshold. So this was our epilepsy brain where the iceberg rides a little bit higher in the water and has this tendency to maybe emerge from the waves and have seizures. And so maybe a medication, really the goal of that is to change the depth of the water. So even with that normal rocking of the waves and the motion of the water, it makes it less likely, because the water is deeper, that even with that same position of the iceberg, that it would be less likely that it would emerge above the top of the waves. So that's the goal of the medications. Is it going to be perfect? Not necessarily. Could certain things still, even with a higher water level, have seizures still emerge? Absolutely. But we're adjusting that threshold a bit. So what do we do for seizures And how can we treat and manage them? How can we be prepared for seizures? So just general advice, having a seizure action plan is very helpful. Many of you might be familiar with this for use in schools, daycare settings, or this is a guideline for non-medical providers, caregivers, and for how you should approach a seizure if it happens. There are different iterations of this. This is a nice one that it was from the Epilepsy Foundation. It looks very much like an asthma action plan, if people are familiar with that. I like that this one in particular has some visuals on what particular seizures can look like for any person, standard care, and then escalating care that's color-coded. So it can include just, again, your standard first aid in that green category, any rescue medications that we'll talk about, and then when to call for additional help in the red category. There are different versions of this through the Child Neurology Foundation and other things. Some of your schools or daycare centers might have specific ones they want to use. You don't have to use this one. You should always check with your provider or your school system on what they would like. There are also some other easy visuals that I think are really helpful too. The Epilepsy Foundation also has this available. You can screenshot this. This is really helpful for older individuals. It can be a cell phone lock screen. I've seen these printed out and used as either backpack tags or wheelchair tags so that there's a good, quick, easy visual available so that someone knows how to respond to a seizure, especially because we know that individuals aren't necessarily in their, for example, school setting all day. They're going to be out and doing other things. And if a seizure were to happen in a different scenario, people would know how to respond. Some of you also might be familiar with emergency medications. We have a few different formulations available. Diastat is a rectal diazepam gel that comes in a pre-filled syringe, so it looks like this. It's dialed to a dose that is appropriate for your age and size. It is administered via the rectum for someone who's having a seizure that is lasting beyond a certain amount of time. We also have some other non-rectal based treatments, which is for bigger kids, older kids, maybe people who wouldn't want to be in a scenario where you would have to pull their pants down in a public situation and administer something rectally. We have other ways to do this. So there's a clonazepam wafer tablet that can be put on the inside of the cheek and dissolves. And we also have in the US, we have two different approved nasal-based treatments. So there's Valtoco, which is now in the US approved down to age 2, which is intranasal diazepam, and then Nasolam, which looks very similar, but I didn't put a picture in here, which is intranasal midazolam for ages 12 and up in the United States. It's helpful to know about some seizure monitoring or home-based monitoring things that are available. You should always talk to your own medical provider about these things. There's just the easy way of doing calendars and diaries and keeping track of things on paper, but there are also some devices that are available. I'm not going to give you any particular advice on whether you should or shouldn't be using such devices. I think everything has its own challenges and potential benefits. There are some things that are watch-based things that measure motion or accelerometry. There are other things that can detect muscle activity or changes in things like heart rate or other autonomic functions. These can potentially be helpful tools. They also come with some pitfalls. They might not detect certain types of seizures. And so you should definitely talk to your own provider again to see if some of these things would be right for you. We oftentimes, for a lot of other disorders, get questions about seizure dogs or service animals. Again, talk to your own provider about these. I'm not providing advice on whether you should or should not use these options. But generally, when we're thinking about seizure dogs, they come as two particular types. There's a seizure response dog or a service animal that provides support when a seizure does occur, can go to the individual and respond to them, keep them comfortable, and soothe them until they're back to their baseline. And there's also the seizure detecting dog. There's really maybe less evidence behind this or how well that actually works. And these are supposed to be the dogs that identify a seizure before it even happens. So grain of salt with that one. So we talked a lot about seizures and how we're going to manage seizures overall, but let's maybe bring it in a little more specifically to LCC at this point. You've seen some of these graphs already. They're on the wall. Dr. Fraser showed these briefly as well. But how common are seizures in epilepsy and LCC? And so here we can see in a cohort of 31 individuals that about a third of them actually had not had a seizure or did not have seizures. And then when we add in the light blue section, so individuals who have had seizures, but they are resolved. They're in that last category of our new ILAE criteria, and they're not currently on any anti-seizure medications. So those two categories together actually comprise about half of individuals. Then there's about a quarter of folks who are on a single anti-seizure medication, and then another approximately quarter who are on 2+ anti-seizure medications or a seizure medication and a non-medication-based therapy. And you saw this one as well. When do seizures start? Far and away in LCC, seizure onset is in younger age groups, less than 1 or in the 1 to 5, and very few individuals with a later onset. And here is a bubble chart of some of the common medications that are used. So the bigger the circle, the more individuals were on this medication at the time of this data collection. This does not necessarily reflect other medications that have been tried for individuals in the past that they were not currently taking at the time this data was collected. It also does not reflect medications that have been tried since this data was collected. But we can see that the most common medications that we use, the most common one is levetiracetam. You may recognize that as a brand name Keppra. That's a broad spectrum one. And then that was closely followed by oxcarbazepine, lacosamide, lamotrigine, and then some additional medications. So brevitiracetam, clobazam, rufinamide, valproate, and topiramate were also being used in somewhat smaller numbers than the big four. All right. So when we're thinking about medications, you have to also consider what the side effects could be. And that has a lot to do with our prescribing patterns, I would say. Levetiracetam, again, which is the most commonly used, can have, first of all, I don't want to downplay it. It's a great medication. It doesn't interact with other medicines. It's fairly easy to use and prescribe and titrate, and we can change doses relatively quickly on it, which is helpful. But it does have these potential side effects of irritability and behavior change, and that can be really limiting for LCC individuals or for other folks as well. Brevitiracetam is like the cousin to levetiracetam. It is very similar. It is maybe less likely to cause some of that irritability, but it still certainly can occur. With other medications, again, we have to think about with oxcarbazepine, sedation, dizziness. We have to monitor sodium levels frequently, not frequently, but in many individuals, because we need to make sure that they are not dropping down low on their sodium levels in their blood. And then lacosamide, especially if we're going to give big doses or IV doses, then we still have to check EKGs to look for evidence of predisposition to cardiac arrhythmias or abnormal heart rhythms. Lamotrigine, which is again another commonly used one, fairly well tolerated, but if anyone in here is familiar with it, you might recall you had to go very slowly when that was started, because if we go too quickly with that medication, there's a risk of a pretty severe, dangerous type of reaction called Stevens-Johnson. So all of these medications can come with some possible side effects, so we always have to take those things into account when we're choosing our medications. We do have some individuals who have tried other non-pharmacologic or non-medication-based treatments for seizures that have been used in a lot of other conditions as well. So the ketogenic diet is something that is available. This is a very specialized diet. People are oftentimes familiar with it from a more fad diet standpoint as well. But from a medical standpoint, it's a very highly regulated diet where you work with a nutritionist dietitian to make sure you're getting appropriate nutrition and following the patterns that you need to. It's a very high fat, extremely low carb, and medium protein diet that, again, is very strictly regulated and also comes with its own set of side effects. Keep that in mind. And then surgical management as well. So I put cyst management in here because a lot of people are familiar with that. Maybe the primary goal of the cyst management isn't always necessarily seizures specifically, but it could be. And then we have implantable devices that are also options and available. So there's RNS, which is a responsive neurostimulator. So basically, this device is implanted into the brain, has EEG leads, then responds to a seizure as it starts to provide electrical stimulation to a seizure focus for a focal seizure when that seizure is starting. There's also VNS, or vagus nerve stimulator, so this is what the RNS looks like. This is a VNS where there's a stimulator that's implanted under, like in the chest under the clavicle, and that is then connected and stimulates the vagus nerve to provide feedback and reduce seizures. And there's also DBS, which can be used for seizures as well, but not likely for the types of seizures or the profile of seizures that we're seeing in LCC, but it does exist. So overall, seizures are common in LCC, but also there are plenty of individuals who do not experience seizures. Oftentimes, these start in younger ages. In some individuals, it can be challenging to treat the seizures, but not in everyone. And then in terms of the medications that we're seeing, there's not necessarily a specific medication that seems to treat seizures in LCC the best. What we really see is that the profile of the meds that are prescribed are reflective of our prescribing patterns in neurology overall. And additionally, non-medication-based treatments are also an option. We don't have a whole lot of information right now on outcomes specific in LCC, but those also exist. I want to thank Ashley for organizing and everyone here and our wonderful team back at home in DC. And that's what I have. Yeah.